Welcome back to PedsCrit. I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
And I'm Al Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York.
And we are talking about VA ECMO and septic shock with Dr. Abhinav Totapally and Dr. Brian Bridges. Would both of you please introduce yourself and tell us about your academic and clinical interests related to today's topic?
Sure. My name is Abhinav Totapally. I am a pediatric intensivist at Nicklaus Children's, and I just finished my fellowship at Vanderbilt University. My clinical interests are in ECMO and ECLS, and I'm happy to be here.
And my name is Brian Bridges. I am the Division Chief of Pediatric Critical Care at the Medical University of South Carolina in Charleston, South Carolina. And previously, I was at Vanderbilt and the Children's Hospital there with Abhinav, where he was my fellow, and I was lucky enough to get to work with him. And I was also the medical director of ECMO at Vanderbilt for a little over a decade. So most of my clinical research experience and interests have been with extracorporeal life support.
Oh, wonderful. Well, we're so excited to have you both on. And we also realize that we have the unique opportunity today to really be talking to sort of a mentor and a mentee. You two just published a big paper together titled Central or Peripheral VA ECMO for Pediatric Sepsis, an outcomes comparison in the ELSO dataset from 2020 to 2021. That came out recently in PCCM January 2025. What advice do you two have for both as a junior, maybe a PICU fellow coming into a scene and looking for mentorship and really using that relationship, and as a senior faculty seeing an opportunity in someone and really establishing and creating a successful mentorship relationship?
Great question. I guess I'll answer from the trainee fellow perspective. I think the first thing is that as a trainee, you have to think about what you like and what you enjoy. I know that's hard when you first start fellowship because you are trying to figure out how to put lines in and how to survive in the unit. You take those first 6 months to see what you enjoy and what you like. And then this is advice actually Dr. Bridges gave me, and I've taken this forward, is kind of the best research ideas come from if you are at the bedside, you have a question, or there's a patient that you wonder about. And that's kind of how this whole project came about for me. The best thing is sometimes when you reach out to somebody about what do you think about this, it does two things. One is it's going to be something you enjoy and you are interested in, which I think it's going to meet a better product. And I think it also shows initiative. And I think, the fellow or the mentor-mentee relationship, I think is a two-way street, right? I think you need someone who is going to coach you and be there for you and be responsive to you. But you, I think as a mentee, also have to have the initiative, be willing to troubleshoot and figure out problems on your own as well, and just have a general curiosity about how to do things, right? We all have to do a fellowship project, but at the same time, I think if you can make it into something that you really enjoy, and then I think that you yourself are interested in, I think it won't be as tedious, hopefully, get it over to the finish line. I do think it might set you up for the future. And so that's certainly my experience. And so, this project basically kind of jump-started a lot of things for me.
Yeah, no, I think it's a funny thing. I tried to learn from my experiences as a fellow, and I had a great fellowship program. But, I'll be completely honest. I did a research project that I maybe didn't have as much passion for as I should have, and I got it done and I got it published, and that's great. But, I told myself that going forward in my own career as attending in an academic medical center that, I was going to embrace and do the clinical research that I was passionate about and answer questions that I really wanted to know the answer to, right? And I feel like that has led to a success. And unfortunately, maybe to my boss's chagrin, I don't have, huge research grants. I do a lot of underfunded clinical research with extracorporeal life support, but it's okay. I'm answering questions that I want to know the answer to. I'm asking those questions, right? And I find that other people who do ECMO, they seem to have the same questions, and they seem to be looking for the same answers. It's a small community. And I think the best piece of advice I ever received when I became an attending was from a guy named Jeffrey Fleming, who was my partner at Vanderbilt. And he told me, in an academic PICU, you're never alone, okay? You think you have to come up with all the answers all by yourself when you're the attending, and that's not the way it works. You're surrounded by smart people in your division and other subspecialties. You'll do better, and your patients will do better if you ask for help. And I started realizing I had more questions to answer than I had time. And then I would have fellows who would be like, hey, I saw that you're working with ECMO and anticoagulation or ECMO and kidney support therapy. That's really cool. Could I help? And I was like, sure you can. I think of anything I've ever done, the thing I'm most proud of is that, the fellows that I've worked with and done clinical research with are like Abhinav, right? Now he's a leader of ECMO at his respective children's hospital there in Miami at Nicklaus Children's, right? And to me, that is the most gratifying part of this.
How wonderful is it to see the results from all that hard work? Abhinav, in your way, putting in the legwork to find mentorship, to get the project going, to give you a head start on your new career, and for Brian to see the results from working hard, giving extra time when you feel like you probably didn't have much time already, just seeing how that's given him a springboard. And mentorship is a common theme here on PedScript. Hearing about how people go on to have fulfilling and high impact careers, and they look back and reflect, it's probably a very small number of individuals who really help propel them to that point. And in the same line, we appreciate the virtual mentorship you've given to Alice and me today and the listeners on the call. As we conclude our introduction here and move on to VA ECMO and septic shock, any conflicts of interest to disclose?
None for me.
I have no conflicts of interest.
Wonderful. Let's go ahead and jump into a case. So you've got a previously healthy 3-year-old boy admitted to the pediatric ICU with suspected septic shock. He receives broad-spectrum antibiotics and 60 mLs per kilo of crystalloid in the emergency department. Unfortunately, his shock persists despite high-dose epinephrine, norepinephrine, and vasopressin infusions and initiation of stress-dose hydrocortisone. The team is considering cannulating the patient to VA ECMO. So to get things started, will you tell us more about the rationale supporting the use of VA ECMO in patients like this with refractory septic shock? Why should we do this?
So the rationale for VA ECMO here is sometimes the rationale for VA ECMO, and in most cases, which is providing good delivery of oxygen to tissues. The goal is to do it in a timely fashion and kind of restore end organ function and preserve end organ function. This kid is developing what we call refractory septic shock, which is catecholamiine resistant, and then depending on what else is happening, the lactate's rising, end organ dysfunction is happening. And so here is to really restore your delivery of oxygen to end organs. The other thing I also think about is also buying time for your antibiotics to work. Is just the other part of all of this. So I think that's kind of the two main things I think about here.
Yeah, no, I think that's well stated. I do think, in the PICU, it's all about end organ delivery of oxygen, right? And for a patient with refractory septic shock who has cardiovascular failure, do they have pump failure? Do they have, excessively low systemic vascular resistance? Their organs don't get the perfusion pressure that they need. And it's always the question, right? If I give this patient 30 minutes, 40 minutes, 60 minutes, will their hemodynamics get better? Will their blood pressure get better? Will their shock get better? And that's always the difficult thing, right? You see a patient who has escalating inotropes and pressors and worsening lactate and worsening signs of end organ dysfunction. The place for ECMO is definitely before you have an episode of cardiac arrest, right? Because we know, even though it's possible, and there's a whole category of ECMO for cardiac arrest, if the etiology of that arrest is sepsis, we know the outcomes are much poorer if the patient arrests before ECMO cannulation. So as the pediatric critical care physician and as the ECMO person at the bedside, your job is end organ delivery of oxygen. And if you fail everything, it is better to cannulate sooner rather than later, right? It's hard to know, I get asked, well, what kinds of doses of norepi or epi are you going to use, right? The short answer is whatever you need to, especially if you're trying to bridge to ECMO. I try to avoid arbitrary limits on inotropes and pressors. I have personally, and I'm not saying this is something that's going to happen to you very often, but I have used norepinephrine doses of 1 mic per kilo per minute and epinephrine doses of 1 mic per kilo per minute and vaso to bridge a patient onto ECMO, right? I've given epi spritzers, and sometimes that's what you have to do to prevent arrest to get on ECMO, all right? That's not a long-term plan, but you've got to do what you got to do sometimes to give your surgeon time to cannulate.
As I reflect on what you shared, if a trainee was approaching this for the first time, VA ECMO doesn't fix septic shock. It simply enables oxygen delivery while your antibiotics, your source control, that hyperinflammatory milieu settles, and that patient can recover their multi-organ dysfunction. When we think about taking care of kids with severe sepsis, septic shock, if VA ECMO is the ultimate way to support all of them, it would make one think, why don't we do a lot more VA ECMO? Inside this context of patients with septic shock, why might VA ECMO not be helpful for some of these patients?
That's a great question. And I think this kind of touches on a little bit of the candidacy question as well, right? And I think that the first thing is anytime you put anyone on ECMO is why you're doing it, is it reversible, right? And sepsis is theoretically a reversible condition, right? If you give antibiotics, they may get better. And you're essentially, what you're doing, you're just buying time, right? You're supporting the patient to buy time for your, like you said, your antibiotics, your source control to work. But I think it also depends on kind of the type of patient and what's causing it. If it's severe immunocompromised with already progressive, very awful organ dysfunction, who's maybe already arrested, right? Had a long CPR event, right? I think those patients, it may be that it's too late, right? The benefit of ECMO at that point may be diminished. It's always harder to make that decision, and then I'm making it sound very easy, but it's not, and we all know that. Profound neurological injury, is someone who's already had a significant neurological insult or had one in the past. I think those are the same things that you have to think about. There is a debate about if you are in an extreme vasoplegic state because your SVR is so low, just giving a bunch of cardiac output and your cardiac function is already hyperdynamic in the patient. There's a question is how much VA ECMO would help in that situation. I think that's a little bit harder to say no to, but it does come up. And so I think that's another thing you have to consider. But I think for me, I think it's more about what are your general ECMO contraindications, head bleeds, neurological injury. I definitely think about it again if they've arrested for a long time, before going on ECMO, and how severe is their end organ dysfunction at that time. But that's kind of how I approach it. I don't know if Dr. Bridges has any other thoughts.
I think that's well stated. We just recently had a little bit of a debate, and I think it's going to keep coming up. I think in PICUs across the country and across the world, we're putting sicker patients on ECMO. I still remember a time, and I prize this, but I have every ELSO Red book ever published.
Oh, that's awesome.
And, it wasn't that long ago that sepsis was a contraindication to ECMO. Actually, cardiac arrest used to be a contraindication to ECMO, and now it's its own category, ECPR, right? And the thought is, well, you're septic, you have bacteria, you put a big plastic circuit on, there's no way you can clear an infection. And that's obviously not true because, well, Abhinav just did a whole big paper showing you 1,200 patients where they can recover. It's important that the patient have a reversible diagnosis and an underlying reversible condition. So what that means is that like sepsis is often a reversible diagnosis. But what about the patient's condition? And as we put on sicker patients with more comorbidities over time, does that patient have unfortunate malignancy for which they cannot recover? Does this patient have a genetic or metabolic condition, mitochondrial disease for which they cannot recover? Or unfortunately, as our patients get more complicated, some of our patients in the PICU have chronic multiple organ dysfunction, right? You think of the patient who had extreme prematurity and static encephalopathy and maybe chronic kidney disease and maybe GI dysfunction. Are you helping them, and will you change their underlying condition by putting them on ECMO? And oftentimes the answer is no. So it's easy to say you'll put a patient on ECMO. Sometimes it's harder to say you won't because you feel like, as you said, ECMO doesn't cure any disease. It just buys you time. Can they recover from their underlying diagnosis and condition?
Oh, absolutely. So we've talked about patients with septic shock who are not likely to benefit from VA ECMO. What are the classic patients who are likely to benefit from VA ECMO? What population do we really feel we could save?
Touching on Dr. Bridges' point, previously healthy children unfortunately have an awful septic shock picture with no other comorbidities. I mean, those are kind of pre-arrest. those are kind of ideal. There is some literature that neonatal sepsis actually has a higher survival, approaching in some cases up to 70% actually. And I think the ones, especially if they have some degree of cardiac dysfunction, be supported well by VA ECMO because you're essentially just giving them that cardiac output. And so those types of patients are going to be the ones that benefit. And the other thing I will say is it's also about the timing of when you initiate it, right? Really hard to do, but when are you going to actually pull the trigger on it? Because we all agree it's probably not best to wait until their lactate's 20 and like their systolics are like 35 and you're basically medically coding them. Sometimes that happens, and I get that, and that you can't help that. In the paper me and Dr. Bridges published, a third of the patients arrested before ECMO. I do think that it's a target that we should work towards, is like trying to get these kids on before they arrest, especially these previously healthy children without a lot of comorbidities, because then you can really preserve their neurological function.
Yeah, this whole research question really came up at the bedside because we had a series of patients in our ICU with group A strep and refractory septic shock that we supported with VA ECMO. And his question, I shared some literature with him from Graham McLaren, who I think is really the authority on septic shock and VA ECMO support, past president of ELSO. He goes, how high should the flow be for this patient? And where should we have cannulated this patient? Should we have cannulated this patient through the chest? And then he goes, can we study this? And I'm like, yes, we can. Actually had to petition the ELSO registry for the data, which they kindly provided. But yeah, I think being aggressive with these patients, especially when they are previously healthy, and I look at VA ECMO for refractory septic shock as both support and platform, in that I can provide non-pulsatile cardiac output to that patient to supplement their native cardiac output. But so many of these kids have acute kidney injury and fluid overload, right? So I've got this big ECMO circuit to which if they require kidney replacement therapy, I can connect it to the ECMO circuit. If they meet TAMOF criteria, have low platelets and multiple organ dysfunction, perhaps they could benefit from therapeutic plasma exchange. A secondary TMA, that again, I can use ECMO as a platform to provide therapeutic plasma exchange, right? That is the model that Matt Payton and Jim Fortenberry taught me at Emory when I was a fellow, and it's something that's really stuck with me. It'd be nice if all these kids just had single organ failure and you could just put them on ECMO and wait for the antibiotics to work. But unfortunately, they usually have multiple organ dysfunction. But I think ECMO is that platform for which you could provide multiple organ support.
Oh, excellent. Now, before we move on to cannulation strategy and how much flow we really need, I would love to ask, especially for the early fellows, when you're cannulating a patient or deciding to cannulate for ARDS, you have the oxygenation index, right? Like you kind of have that objective, we'll calculate a number and at least I can give myself some mental stopping points of when do I consider. Do you have numbers, whether it's vasoactive requirement, lactate, something like that, where you kind of force yourself to consider cannulation in kids with septic shock?
So the short answer is really no, I guess.
Okay.
There's some things that you can look at. There is one paper said like if your systolic is for pediatric patients under 50 with rising lactate and with fluid resuscitation vasopressors. To me, it's more what is your shock right now? And then what is your trajectory? Where are you going to be in like 6 hours, do you think? If you don't do ECMO. Are you like having a hard time keeping up with their shock, with their vasopressors, and you can see the end organs are getting worse? Then I think that's the time to really think about putting them on. That to me is the better way to think about it, is where are you right now? How much support are you giving? And where are you going to be in like 6 hours, you think? If the answer is, I really think we're going to be in a lot worse situation, then maybe it's time to go ahead and put them on. There was a paper that came out between the Australian and New Zealand centers. They kind of like looked at both countries. They said that if your mortality risk hits 50%, basically, that you should really consider putting them on. How they calculated their mortality risk was a combination of rising lactate, cardiac dysfunction, your PF ratio and if you've arrested beforehand. So that just gets a sense like if you have significant cardiac dysfunction, circulatory failure with other end organ effects, then I think you should probably be thinking about ECMO.
Yeah, I wish we did have like the OI version of ARDS for septic shock. I guess we could come up with that and call it the Totapally index, but that's to be a good idea. And
TI.
yeah. But it is hard. Sepsis is not the same in every patient. You think about the little baby with cold extremities and poor cardiac output with sepsis versus your teenager with flash capillary refill and actually hyperdynamic cardiac output, right? Which is the more of sort of the adult model of sepsis. And then there's everything in between. Those patients can switch back and forth, right, in one ICU stay of what they look like clinically. Trajectory is like everything too, right? If you're an ICU doctor, you're working in your PICU, and your 1-year-old comes up to you intubated on rocket fuel, and if their mean pressure is 90, you feel different than if their mean pressure is 30, right? One of those patients you're going to be able to wean. The other one you're going to be scrambling to add and to stabilize until probably you can get them cannulated if they're a candidate, right? So I think the trajectory is everything. How much fluid they've gotten. Have they gotten steroids? How long have they been sick? Sepsis is such a different beast in different patient populations. It's hard to treat it all the same way.
Isn't trajectory of critical illness one of the most important concepts to keep an eye on? And if a patient, you're maximizing their therapies, but the trajectory of illness is worsening, we need to think about, is our diagnosis not right? Or is there a complication that we haven't identified? Or is our support therapy inadequate? That's when conversations like discussing VA ECMO comes up for sure. Dr. Bridges, you mentioned kind of this paradigm of what's probably warm shock or cold shock. The patient with poor perfusion, suspected cardiac dysfunction versus the patient with sepsis who has flash capillary refill and presumably a profound vasoplegia. When you're considering both ends of the spectrum of those patients for VA ECMO, do you see them differently? And the reason I bring this question up, it's very easy to see that a patient who has no cardiac output hardly from severe cardiac dysfunction, it's easy to see how supporting them via ECMO could easily help them. The cardiac output's going to go from very low to perhaps even normal. But that patient who has lots of vasoplegia, if we can't clamp down against the pump, like how can we sustain organ perfusion with decent blood pressures?
That's a great question. Again, it is about delivery of oxygen to end organs. I've had the privilege of working with a lot of ECMO colleagues from the adult world, and I would say it wasn't that long ago. A lot of them would say, for our patients, they're just vasoplegic. You can just run the ECMO pump, 6-7 liters per minute. It doesn't matter. It won't help them. They have dysoxia. You can't deliver the oxygen to their organs, right? And I think that way of thinking has sort of fallen away a little bit, right? Because, again, it'd be nice if little babies all had cold shock and you just put them on VA ECMO, and all adults had warm vasoplegia and they couldn't be helped, but it's really not that simple. I think the assumption that these adult refractory septic shock patients are vasoplegic and have intact or hyperdynamic cardiac output, that's not really always the case for every patient. And again, those patients can change from warm to cold, from hyperdynamic to poor cardiac output in the course of 12 to 24 hours. I think a lot of people in the ECMO world would hesitate to say this patient can't be helped by ECMO with refractory septic shock, especially if they're previously healthy and were in good condition before their sepsis.
Yeah, I completely agree with that. I think the thing I remember always is that sepsis is a very heterogeneous disease, and it's heterogeneous in the same patient. It can change. People who are very hyperdynamic can become hypodynamic. The other thing I would also say, it's sometimes hard for us to fully judge how vasoplegic or not vasoplegic patients are, to make a decision to not cannulate someone based off that if everything else that Dr. Bridges is saying is still true, like they're a good candidate and everything. I wouldn't use that as a contraindication. And I think that it's important to realize that patients change and that you can use multimodal ways to support patients, whether it be with ECMO with some vasopressor use or, these other ECLS modalities. So I think all of that's fair game, and I wouldn't not offer a therapy because of that.
we know that we need to support these patients with adequate VA ECMO flows until their markers of end organ dysfunction improve. Lactate improves, oxygenation improves, whether you're central venous or your NEERs. What flows do patients in septic shock typically require? And if you weren't getting great oxygen delivery with these typical flows, how high would you try to push it?
That is a fantastic question. There was an article that came out about, I guess it's about 10 years now, that looked at like 150 mLs per kilo per minute of flows in septic shock patients and looked at that compared to conventional sepsis therapy without ECMO and found a survival benefit. And they didn't find that when you just flowed at about 100. And so I think that's been the teaching, is that you flow high. There's a couple of different reasons for that. One is like your VO2 is probably higher in sepsis patients. They're hyperinflamed, they're febrile, their demand of oxygen is higher. There's probably a component of vasoplegia or lower SVR. So I think there's a lot of different reasons why that physiologically makes sense. Whether you're cannulating peripherally or centrally, I think the goal is to push the flows as much as you can. Your rate limiting step here is your drainage cannula, which is why I think it's so important, no matter what cannulation strategy, is to have good drainage. Now, in our study, what we did is we actually looked at flow at 4 and 24 hours and trended the flow and the risk and your mortality. And what we found is that as flow increases in a rate-dependent manner, your mortality does go down. Interestingly enough, though, that you started to see a mortality benefit as soon as your flow reached over 100 or so, or like 110. My opinion is I don't think you need to hit 150. I think you need to give the flow that your patient needs to reverse the shock and preserve your end organ function. And there's a lot to unpack and try to figure out how to do that. I think that's probably maybe from a future research standpoint, I think that's important. There was a paper that came out of UT Southwestern and in Indiana that basically stated that like they were flowing about 100 mLs per kilo per minute on peripheral cannulation, and they were able to get comparable outcomes. So I think the flow question is really about not so much an absolute number, but being able to give the flow that your patient needs quickly. Because I think we saw at 4 hours, we saw that relationship. At 24 hours, albeit it wasn't significant, we saw a trend towards an opposite effect. My interpretation is if you're requiring that high flow at 24 hours, it's probably not the best sign. So I think my feeling is get the kids on early, try to maximize your ECMO circuitry and machinery and drainage to give the flow they need quickly, and then titrate to your patient.
Yeah, I think it is the flow that your patient needs. Patients with refractory septic shock probably need some of the highest flows that you see in ECMO. Abhinav's right. It's how much flow can you get out of the right heart. And then it gets really tricky if you've ever had a patient who was post-CPR, go on ECMO, and they've gotten a bunch of epi. You also are limited a lot of times in your return pressure, right? Your patient got a bunch of epi spritzers and maybe some full code dose epi, and they're on rocket fuel, maybe some norepi, maybe some vaso, and your return pressures can be high, and they don't actually start to go down until some of that epi and that rocket fuel that you needed to get them to go on decreases, right? The pump can only pump against the pressure so hard, and there's a risk of circuit rupture. So what I've done with some of these sepsis patients is, as I'm able to give them the flow that they need, to clear their lactate, to give them a reasonable mean arterial pressure for age, hopefully achieve a desirable mixed venous sat. Hopefully you can come down on some of those pressors that are increasing their SVR. And as you do that, maybe you'll be able to flow higher. And I've even gotten to a situation where I'm trying to flow for organ perfusion. I've come down on my inotropes and pressors, or I'm on a minimal amount of epi. And then, I actually start to add some afterload reducers, right? Some nicardipine. The patients I took care of with Abhinav were group A strep patients who were very sick with refractory sepsis and had purpura fulminans and actually had compromise of extremities. So I was both trying to flow high and afterload reduce with the hope we could save some of their extremities. And some of them it actually worked, some of them it didn't, but I was trying to preserve all the organs plus the extremities. So that was a high flow and afterload reducing sort of model. You can't start off that way in the first hour, but maybe in the first 24 hours. It takes time to build up that flow and to wean off the inotropes and pressors that you needed to get them safely on ECMO.
The biggest thing is, each patient's different. You need to prepare that you're going to need high flows. trying to maximize the delivery as much as possible with all the tricks that you have to do. Like sometimes if you're peripherally cannulating and you don't have an option for central cannulation, you don't have another flow, you have to put another drainage cannula in. These are the things that you got to think about, right? Like, what is the flow that we need and how do I get there? That does vary for each patient, but you have to be prepared to get to higher flows and maximize that with whatever ECMO circuitry and system that you have.